Hello.
Hello.
Hello, everyone. How are you all? Welcome you on our webinar arranged by Orthopaedic Made Easy. It is our third webinar. One of our favorite teacher always says, orthopedics is an ocean and one lifetime is not enough to learn it. So sharing knowledge, gathering new experience only can make significant improvement of knowledge. Today we have with us Dr. Chaudhary Iqbal Mahmood sir. He is Associate Professor BSMMU. He will discuss us with about with meniscus basics. You can ask any question on our Facebook page live or live stream. We will discuss it later at the end of the webinar. Hope you will enjoy our webinar. Hello, sir. How are you?
Fine, thank you. How are you? Good evening. Assalamu alaikum, everybody. Welcome to this webinar session, Orthopedic Made Easy. So I'm gonna talk about meniscus basics. Meniscus is a huge subject. Today I'm going to discuss basics of meniscus, like anatomy, functions, how to diagnose meniscal injury, and the principles of meniscectomy and meniscal repair.
Yeah.
That's it.
Okay, sir. Okay, sir. Now we can go to the screen, and now I am sharing your screen for the lecture. Okay, sir.
Am I audible?
Yes, sir. Perfectly.
Okay. Can you see my screen?
Yes, sir.
Okay. So as I said, meniscus, once it is considered as a vestigial tissue, but now meniscus has got tremendous important functions to support the knee. So the idea is now to save the meniscus rather than meniscectomy. And I have no disclosure, so I'm working as associate professor in Bangabandhu Sheikh Mujib Medical University, and I do private practice in Green Life Medical College Hospital. The word meniscus came from the meniscus, which means crescents. And these are two intra-articular crescent-shaped fibrocartilaginous structures. They are triangular in wedge-shaped structure in cross-section. Meniscal lesions are the most common intra-articular knee injury. Arthroscopic partial meniscectomy and meniscal repair. These are the most frequent surgical procedures, and annual prevalence is quite high, 66 per 100,000 inhabitants, and male-female ratio is 2.5 to 1% to 4.4:1. That's male are suffering from meniscal injury more than the female, and peak incidence is 20 to 29 years old. Medial meniscus tears occurs more often than lateral meniscus. Lateral meniscus tears occurs more commonly with associated ACL injury, and meniscal lesions occurs in all ages. So if we see the incidence of ACL injured patients, so you'll see that 36% medial meniscus tear occur, but out of them 30% unrepairable, and more lateral meniscus tear occur, and out of them 10% are unrepairable. So lateral meniscus healing is better than the medial meniscus. A little bit of anatomy. If you see the video, cadaveric video, here you can see the medial meniscus is asymmetrical. That is, the anterior part is narrow, posterior part is wide, and the anterior horn is small, posterior horn is larger and thicker. The width is larger, and it covers roughly 50% of the articular surface. And this is the meniscus, tibial eminence, just 1 centimeter behind the tibial eminence, posterior of the medial meniscus is atlas. Here you can see the shiny white fibers. Actually, I don't know. This is actually landmark for the PCL reconstruction. And this is intermeniscal ligament. This connects the two meniscus anterior horn together. And if you see the medial meniscus is tightly attached to the capsule and tibial plateau through coronal ligaments. That's why it is less mobile. That's why it's more injured meniscus. And in case of lateral meniscus, you see this is circular, almost round and C-shaped, and it covers about 70% of the articular surface, and it's symmetrical. That means anterior, middle, and posterior part is almost same width. So if you compare medial and lateral meniscus, medial meniscus is larger, and lateral meniscus is smaller, and medial meniscus is less mobile than the lateral meniscus. So that's why lateral meniscus got injured more. Here you can see how mobile is the lateral meniscus is, and in comparison to medial meniscus, it is less mobile. Medial meniscus length is about 4 to 5 centimeter. Lateral meniscus length is about 3 to 4 centimeter, and width is lateral meniscus width is about 3 centimeter. And both the meniscus has two roots, two borders, and two surface. As I already said, that 50% of the medial tibial plateau is covered by medial meniscus, and 60 to 70% lateral tibial plateau is covered by lateral meniscus. I know most of you know this picture. I mean, you have to do, even in OSPE, this kind of picture comes to what are the attachments of the intercondylar area. So here, if you see, it is in front there is this is the anterior horn of the medial meniscus. This is anterior horn of the lateral meniscus. Then the ACL attachment, then the posterior of the lateral meniscus, then posterior of the medial meniscus, then at the back of the below the articular margin is PCL attachment. So this is a very important anatomical picture of attachment of the intercondylar area. And there are some in detail some of the anatomy which will help in repairing and recognizing the tear pattern. This is medial meniscus. If you see medial meniscus, and Simiski, Polish orthopedic surgeon, divides the medial meniscus into 5 zones. This is zone 1, zone 2, and zone 3, and zone 4, zone 5. Zone 4, it is comparatively mobile, and this is the zone where most of the tears occur. In this picture, you can see in zone 4, it is attached to the tibial plateau border with meniscotibial ligament, but above it is free. But in the zone 3, the medial meniscus is attached to the meniscofemoral ligament through femur and meniscotibial ligament through to the tibia. And here you can see it is attached to the deep MCL, deep medial collateral ligament. That's why it is fixed. And this is the lateral meniscus. If you see, lateral meniscus, it is more mobile because it has a loose attachment to the tibial plateau, and it is posteriorly it is attached to the femoral condyle through two ligaments, ligament of Humphrey and ligament of Risberg. Here you can see there are actually 3 ligaments in the meniscus which connects the meniscus to the femoral condyle. One is meniscofemoral ligament. This is the Risberg posterior, then another is anterior, there is another anterior ligament, Humphrey ligament, and the roots, through roots, they are attached to the insertional ligaments, and this is anterior intermeniscal ligament. This is the arthroscopic view. This is the anterior intermeniscal, connects the both meniscus. So these are the anatomical knowledge you have to memorize, because these leads to a correct diagnosis and recognizing the pattern of meniscal lesion during arthroscopic surgery. Meniscal motions, very important. As I told, that lateral meniscus is more mobile. If you see the video, it's about during flexion it goes posteriorly, about 2 centimeters it goes posteriorly, because of its loose attachment. And if you see the MRI during flexion and extension, if you see that how many distance it goes posteriorly. You see that the anterior horn goes posteriorly. So as I said, lateral meniscus is more mobile, and that's why it's less injured meniscus. But medial meniscus is more injured meniscus, because it's attached to the deep MCL joint capsule and through peroneal ligament to the tibia. A little bit of composition. The meniscus is all about water. About 70% it is water and 75% collagen. Out of it, collagen type 1 is more common than 25% other cells and other things, proteoglycans. If you see the cross section, you can see it has 3 layers: superficial, the random oriented fibers; middle, radial fibers. Radial fibers actually connects all the fibers, and the most important one, the circumferential fiber, which is important for hoop stress. Here you can see there are mainly fibroblasts and fibrochondrocytes cells. These are the zones where chondrocyte cells situated, and these are the zones where fibroblasts are situated. So vascularity and cellularity decreases with age. Vascularity decreases from root to body, and cellularity decreases from body to horn. Blood supply, very important, because according to blood supply, we divide the meniscus into 3 zones, and it has an important role during meniscal repair. It is supplied mainly by the medial and lateral geniculate artery through the form a perimeniscal plexus. This is a perimeniscal plexus. This is an important picture. You can see from the capsule perimeniscus plexus, it supplies the meniscus. And we divide the meniscus into red zone through according to blood supply, red-white zone and white-white zone. These are the area where healing is good, and these are the area healing is moderate, and there in this area tear doesn't heal. So if you see this picture, the peripheral part is highly vascular, and also the root. You see how many vessels are there, and this is the arthroscopic picture. The peripheral part is well vascularized. Lateral meniscus is less vascular. That is 10 to 25% of width of the lateral meniscus is vascular, but 10 to 13% width of the medial meniscus is vascular. Here you can see 10 to 25% is vascular. Function: meniscus has got very important functions: load transmission and shock absorption. Very important. The load, the hoop stress, when we bear weight, the hoop stress then dissipated circumferentially throughout the knee in the presence of meniscus. So it is very important. In case of meniscectomy, these function lost and osteoarthritis occurs. Then it increases the joint congruity. It also helps in joint lubrication and nutrient distribution. Also has many proprioceptors and helps in proprioceptions of the knee. So medial meniscus carries 50% of the load in medial compartment. Lateral meniscus carries 70% of the load in lateral compartment. Another important function is meniscus act as a secondary stabilizers in anterior translation and rotation. Particularly anterior translation is caused by its attachment between the two meniscus by anterior intermeniscal ligament, and posterior translation is performed by meniscofemoral ligaments. It also prevent rotation with their roots attachment. If you see this picture here, you can see that the lateral meniscus is the medial meniscus. Lateral meniscus tibial plateau is convex, and tibial meniscus tibial medial side of the tibial plateau is concave. So due to lateral meniscus, it increases the congruency of the lateral side of the joint more than the medial meniscus. Think about it without meniscus, the convex surface, the friction which can lead to severe osteoarthritis. So lateral meniscus plays an important role in lateral compartment of the knee. Biomechanics is a little bit of biomechanics. Menisci transmit, as I already said, that 50 to 70% axial load, 85% axial load in 90-degree of flexion, decrease peak contact stresses at the articular surface by 100 to 200%. And posterior and peripheral joints are the most important side that decreases the contact stresses. Here you can see this is the meniscectomy. After meniscectomy, you can see that increases the contact stresses, but this is without meniscectomy and without meniscectomy. So meniscectomy increases the contact stresses, which ultimately leads to osteoarthritis. Now what are the types and classification? Very important thing: types and classification of meniscal tear. There is a well-accepted classification by ISACOS. This is the International Society of Arthroscopy, Knee and Orthopedic Surgery. They divided they classified the tears according to tear depth, partial or complete, location, that is outer zone, mid zone, inner zone, and the central or to the popliteal height of tear pattern, whether it is a longitudinal, horizontal, vertical, and quality of tissue, degenerative or non-degenerative. Here you go, the gist of this. And according to vascular supply, we can divide the zones into red, white, and white. There are special location. Don't forget this location for the meniscus the pathology. That is the root tears and ramp lesion. These are the capsular lesion. We separate the capsule from the middle meniscus. Just to explain how we do classify or the meniscus, this is the easiest way. Here you can see this is the white zone, this is the red white zone, and this is the red zone. This is the red zone tear, this is a white zone tear, as the left white zone tear. These are the areas where healing is the most healing occurs. This area. Here you can see red, white, and white zone, because these are the areas are well vascularized. And also it can be divided into posterior part, mid third, and anterior part. Posterior third, most of the tears occur in the posterior third of the meniscus. And there is another type of meniscus as the discoid meniscus, specialized one, and this is also classified according to normal, incomplete, and complete. I think no details is required at this moment. So as a whole, if we see the longitudinal tear is the most common, about 22%. Then degenerative tear, that is the horizontal tear, 25% is the most common. Then longitudinal tear, then radial tear, root tear also common, and complex tear 9%. Here are some examples of arthroscopic view of the meniscal tear. This is the degenerative one. This is the longitudinal one. Along the axis of the meniscus, this is the longitudinal one. This is the horizontal one. You can see between two lips, and this is the longitudinal one, and this is the radial one. Traumatic tears are more common. Young athletic persons got injured. When they got injured, they usually comes with traumatic longitudinal tear. And degenerative tears actually occurs more commonly above 40 years old persons with degeneration of the joint. They are usually not amenable for repair. And bucket endial tear, another special type of tear that is the when longitudinal tear occurs and the inner flap goes into the intercondylar notch, it traps and causes locking. This is the bucket endial tear. Here you can see this is the intercondylar area. This is the flap of the meniscus, and after meniscectomy. And what is discoid meniscus? This is special type of this is a congenital actually abnormality. The best congenital. There are several theories. Normally it is meniscal is accretion shaped, but in case of discoid meniscus, this is disc shaped. So these are the disc shaped meniscus are more prone to injury. This is the arthroscopic view of the discoid meniscus. So how can you diagnose meniscal injury? So an important step, if you want to define the treatment before diagnosis, you have to take a accurate history. You have to do a physical examination, then investigation like radiograph, MRI, ultrasonography, CT. But MRI is the most important investigation. So trauma, like a elderly person just fall down in the floor and got injured and can have a meniscal tear. Most the mechanism mainly twisting with in inflection and twisting that femur rotates within the tibia and causes meniscal injury. So if we take history, you have to in history you have to take what kind of trauma, mechanism of trauma, and the patient has locking or came without locking. Usually they came with pain, recurrent swelling, sensation of catches, clicks or jerks in the knee, sensation of giving away. And if we do examination, all of you know that look, feel, move special tests, neurovascular tests. You can find limping, joint line tenderness, very important, quad busting, swelling, and effusion. Sometimes locking, that is inability to extend the knee. This is the locking. And special says McMurray test, Thessaly, and Apley's grinding test. Here you can say McMurray. You all know that McMurray test. We flex the knee, and then for medial meniscus, internal, external. This is for lateral meniscus. Internal rotate the leg and give the varus stress. Then extend the knee. You can feel click or pain or see the patient face for pain. This is not so sensitive McMurray. So and McMurray test for medial meniscus same, but opposite external rotation and valgus strain. Thessaly, this is more specific than the McMurray, but it's difficult to do with the patient. You stand the patient with the affected part on the ground and or 5 to 20 degree flexion, then rotate the knee so that patient feel pain. And please compression or grinding, it is a very low specific and sensitive test. What are the imaging for meniscus? That is the X-ray, ultrasound, MRI. We have to do X-ray to exclude other injuries. Like in this case, you can see there is a second fracture, which means there is ACL injury. Here you can see the avulsion, tibial avulsion fracture. Here you can see that the fluid fat level. That means there is effusion. Meniscal injury comes with effusion within 48 hours. And then here is you can see the degenerative changes. It's very important to detect the varus, because if you got meniscal injury with varus, sometimes you have to do a varus osteotomy, valgus osteotomy. And here you can see discoid meniscus features, that is the squaring of the lateral meniscus, cupping of the lateral tibial plateau, and widening of the lateral joint. And after post-meniscectomy, Fairbanks described the changes that occurs in the tibia, in the knee joint, which includes squaring of the femoral condyle, peaking of the tibial spine, decreased joint space, and subcondylar sclerosis. MRI provides what are the type of, what the theories are, the degenerative or non-degenerative location, extent, distance from the periphery root, whether there is displacement fragment or not. These are the types of MRI you comes through when patient do MRI. There are three sections: sagittal, coronal, and axial. These are the sagittal section. This is T1. This is T2. Here T2, you can see the fluid bright. T1 is fluid is less bright, and this is a cadaveric picture. And this is the coronal section. That's the AP view. You can say this T1, T2, and here you can see the meniscus triangle, and this is axial T1, T2, and this is the meniscus. This is the meniscus. This meniscus. Normal meniscus uniformly dark. You can see triangular structure, sharp triangular structure. MRI is about 93% sensitive for medial and 80% sensitive for lateral. And these are bow tie shaped on the sagittal section. Medial meniscus, well, how can you say that it's medial or lateral? If you see that the tibia is champagne glass shaped, so also the posterior horn is bigger than the anterior horn. On the lateral side, you can see fibula, and both horns are equal in shape. If you cut a section through this area, you can see that this is disc shaped because this is if you cut this through, you can see this type of picture. If you cut this, you can see the triangle. Also, the lateral meniscus, if you cut through this, you can see the disc shaped, and if you cut through this, you can see triangle. Grades of meniscus, that is the grade 0 is no signal changes, grade 1 is globular changes, grade 2 is linear changes, but these changes does not communicate with the surfaces. So these are the you can't see this injury on the arthroscope. These are usually degenerative changes, and when the signal change communicate with the upper surface lower surface, there is a complete tear. This is the meniscal. Here you can see. These are the grading: grade 1 globular change, grade 2 linear, the degenerative, and grade 3. You can see the communicate with the articular surface. This is the abnormal meniscus signal that touches the articular surface. As I already said, this is the abnormal signal, and this signal that doesn't touch the articular surface is not a tear injury. Some of the common longitudinal tear, you can see this is longitudinal. You can longitudinal particle. You can see this type of signal change on sagittal view from upper surface to lower surface. This is the horizontal. This is usually degenerative, and you can see this horizontal sandwich between black and upper black, lower black, and in between white signal. Often degenerative. Radial tear. You can see radial tear. Here you can see the discontinuity of the two horn, like a white signal. Axial. You can see this is the radial tear from inner surface to periphery. Flap tear. There is a horizontal tear with a vertical, so it is a flap tear. Bucket handle tear is important. All you know the double PCL sign. This is the PCL. This another looks like a PCL. This is a double gun. This is a pathognomic of the bucket handle tear. Complex tear, different type, some horizontal, some vertical. This is multiple plane signal changes. This is complex tear. And discoid, you can see that 3 consecutive sagittal section. You see the disc shaped black signal. That's 1, 2, 3. All section you can see the disc shaped. In this section, you have to see the triangle, but here you can see disc shaped. So this is disc shaped. Discoid meniscus, as I have told you, 1, 2, 3, 3 consecutive sagittal section or coronal section, disc shaped, black signal. Meniscus is discoid meniscus. Risk factor for meniscal tear: gender, age, football, types of play, football, rugby, stair climb. These are the high risk factors. Moderate risk, BMI, more BMI, more prone to injury, swimming, other sports, and low risk, running and walking. Treatment: in the absence of intermittent swelling, catching, locking, or giving away, meniscal tears, degenerative in nature, may be treated conservatively. That is restrictive activities, analgesic, knee brace, and physiotherapy exercise. But younger patient with acute tears, patient with tears causing mechanical symptoms may need surgical treatment. Surgical treatment consists of meniscectomy, repair, and meniscal transplantation. Repair: there are 4 types of repair: inside out, which needs Jones specific cannula; outside in, which needs also cannula, or we can use large pore needle cannula. All inside, these are the commercially available device all inside, and but expensive, and hybrid, a combination of the two or more technique. The meniscectomy, there are partial meniscectomy and total meniscectomy, which is nowadays obsolete almost, and these may be arthroscopic or open. Meniscal transplant, this is not available in our country. In Western countries, allograft is available for transplantation. This is meniscectomy and the meniscectomy patient, then meniscal transplantation after meniscal transplantation. So now the goal is to save the meniscus. So you have to save the meniscus, because I have already said the very important function. Otherwise, the young person after meniscectomy, it can lead to osteoarthritis. So you have to, the now slogan is save the meniscus, because without without keeping the meniscus, it can lead to severe osteoarthritis. Here you can see that all the cartilage has gone after meniscectomy. So this is a good paper, JBJS. After meniscectomy, osteoarthritis occurs almost 5 to 10 years later. There is another factor, meniscectomy as a risk factor for knee osteoarthritis, systemic review. You can see after resection, the chance of after meniscectomy is increased. First, I would like to discuss about the meniscectomy. Then, even after meniscectomy or even before meniscectomy or meniscectomy, you have to evaluate the knee joint with arthroscope. That is to localize the tear and size of the tear, whether the tear is stable or unstable. You see the video, and what was the blood supply, what the other status of the other structure like ligament, ACL, PCL, or the cartilage. Here is the middle gutter. You can see, go to the middle gutter to see any loose bodies, and this is the patellofemoral joint. Then the lateral gutter. Just forward. Now we are in the compartment. Here you can see there is a tear. Here, the radial tear, oblique radial tear. Here you can see the radial tear. It's well vascularized. Yes, yeah. Yes, you can see this radial tear. It is stable, but the tear, in this case, yeah, the tissue is not, the quality of tissue is not good. So you can, we have to do, I had to do meniscectomy, partial meniscectomy. Next slide. Partial meniscectomy, the goal is to amputate the mobile segments and keep the stable rim in the knee. So any tags and pieces that may catch in the joint, you have to resect it. Here you can see you have to resect this type of part in case of longitudinal tear. This is the radial tear, and this is the radial tear. You have to resect in this amount of tissue. Here the degenerative tear. This is the before meniscectomy. This is after meniscectomy. But look at the cartilage. Here you can see the meniscectomy. How can you do? Similar patient. This is the radial tear. We do meniscectomy with punch, basket punch, and combination of shaver and basket punch. And we're shaving the frail tissue first. You have to be very careful not to injure the cartilage, you know, with shaver, because shaver is a very helpful instrument but very dangerous. You have to be very careful. First you shave the frail tissue, and then you can use the punch to trim the remaining of the tissue and keep the stable rim. Here you can see almost after partial meniscectomy, large bit of tissue was removed to make it smooth. Lastly, to make it smooth, here you can see well meniscectomized, partial meniscectomized, middle meniscus. The edges are smooth, and the unstable portion was removed. So now meniscus repair. How can I do what? What are the principles of uh, uh, what are the principles of meniscal repair? That is, you have to. It's like a fracture. You have to reduce first, then some circumferential compression with suture. This is the circumferential compression of the by suture. You can see, and you have to augment the repair. Repair technique. If we divide the zone, this is the uh, mid portion. In this portion we can do inside out. These are the technique inside out. These are the technical gold standard from inner side of the meniscus from outside. But the one disadvantage, you have to do a incision to make the knot. Then posterior part you can do also all inside repair. Um, because in this situation, all inside out is very dangerous, because the needle may go out posteriorly and injure the neurovascular structures. And anterior third, outside in, from outside to in. You have to push the needle from outside to in. So these are the basic principles of meniscal repair. Mid portion inside out, posterior third all inside, and anterior third outside in technique. Here is a short video in the model. You can see inside out technique. Jones cannula, you put the needle with suture through the cannula and take out outside vertical mattress or horizontal mattress, then another one. Then here you can tie the knot. The outside in, same, you put the needle from outside and take out the suture outside, and then tie the knot. This is outside in. Inside out is more commonly done. So inside out repair is a gold standard, and but less cost, and the punctured matter lesser diameter, so less injury to the meniscus. Here you can see how inside out arthroscopy inside out. First, we have to rub the border, the rough border rasping to increase the blood supply. This is the rasping diamond rubs. You have to rub the inner border and outer border of the tear, and and this is the repair inside it. You put a one stitch on the inner superior surface, another on the upper surface, vertical mattress. 1, 2, 3 between stitch 5 millimeter gap. The well repaired longitudinal tear. Repair principles, that is, you can the principle is that you have to put in case of vertical mattress, alternatively superior surface and inferior surface sutures. These are the actually advanced techniques, and just the principles. I am discussing a little bit of principles. Repair technique, you have in case of inside out, you have to do a medial side incision to tie the knot, and lateral side incision between ITB and LCL. Here you can see ITB and LCL inside out technique. Outside in, as already used, I said, easy, but only anterior third, where the tear is less common. These are the outer repair. You can see the suture. And all inside, there are different devices, but very expensive, but very easy to do. It is actually, our patients are not ready to do with the all inside instrument yet. So as a whole, meniscal, in case of meniscal, you have to choose the right patient. So you have to consider the region of the meniscal tear, age of the patient, Type of tear, longitudinal and radial tear are more amenable for repair. Chronicity, more chronic, less likely to repair. Lateral meniscus repaired well and heal well. Limb enamel must be corrected. And associated ACL in reconstruction, you have to associated ACL reconstruction. So the meniscal repair technique is meniscal healing is good after ACL reconstruction. If you consider what are the indication for repair, radial tears, horizontal tear, longitudinal, root tear. These are the tears which can be repaired well if they come early. And the area, if you consider the area, red area, that is from the capsule to 2 millimeter length. These are the area where meniscal repair is very good, healing is very good, and more than 4 millimeter is the healing is not good. So this is the white area. Length less than 1 centimeter, repair is good. Sorry, you don't need repair, but more than 4 centimeter unstable, you need repair. Types of tear, longitudinal rear tear are frequently repaired. Root tears, another important tears, but you have to look for the root tears because it is said that root tear is equivalent to total meniscectomy. So root tear is very important. I'm not gonna discuss detail about the root tear. These are the advanced technique. If I got chance, I will discuss another day. Ramp lesion, another lesion, capsule from capsule to medial meniscus. There is separation. These are the very difficult to find even in MRI. You have to look for during arthroscopy. Timing less than 3 months is good for repair. Young patient is good for repair. Repair enhancement. How can you enhance the repair? There are several techniques. There is the meniscal abrasion with the rubs, bone marrow stimulation. This is the rubs. This is the trephination. That is vascular access channel. You have to needling the synovial tissue to allow bleeding. And then these are the microfracture in the non-articular area, in the medial surface of the lateral condyle. If isolated meniscal repair, if you do isolated meniscal, then you can do microfracture with all. And if you do ACL, then you don't need this procedure because already tunnel makes you the hole. There you can use PRP scaffold. There are several techniques to augment meniscal healing. Fibrin clot, you can use also fibrin clot in the repair. Complication in case of repair, you see putting the needle through the knee joint even posteriorly is very dangerous because look at the popliteal vessel, how far it is from the tibial knee joint. So you have to be very careful. If you see this video,
meniscal repair, for example, here with all inside fast fix, the dangerous victims.
If you lateral meniscus to the lateral portal, look at the popliteal vessels is very dangerous. You can injure the patient. So you have to put the needle from here to here. Yeah, from the lateral portal, from the medial portal for lateral meniscus repair. Okay. Outcome is very good. 72% manual meniscal repair was considered successful. 85% lateral meniscus repair was successful. At last, I would like to share a very rare case. There is a simultaneous and the same knee, both sides, bucket handle tear. This is the medial side, and this is the lateral side. I already presented this case in the APCAS, and this is the only third case reported in the literature. So very rare case. Bucket handle tear, double bucket handle tear, in the same knee. And this is another international publication of mine, which is published 2017, symptomatic discoid lateral meniscus treated with arthroscopic procedure, observation in 20 knees. So in conclusion, meniscal injury is a very common injury, commonly associated with ACL injury. Diagnosis is made by typical clinical signs and MRI. Only symptomatic knee joints are being treated. Meniscectomy can lead to early OA. Meniscal preservation is now goal. Try to repair meniscus arthroscopically if indicated, particularly in young patients. Save the meniscus. Thank you very much for your patience hearing.
Thank you, sir. Thank you, sir, Dr. Iqbal Mahmood Chaudhary, for your nice elaborated discussion session on meniscus basic. We have a lot of viewers watching our webinar. Renowned arthroscopic surgeon Dr. Jahangir Hossain sir wishes us best wish to you and organizers. Sir, we have some question.
Yes.
Now we can go to question and answer session. Uh,
Okay.
Dr. Hasibuzzaman asked a
Yes.
question: why double PCL sign in bucket handle tear? Why we see double PCL sign in bucket handle
Because
tear?
in, bucket handle tear is common in medial meniscus. So when the bucket handle longitudinal tear occur, and when the length of the tear is bigger, so the inner flap during movement of the inner flap got stuck in the intercondylar notch, intercondylar area. So you know the PCL is also situated in the intercondylar area. The flap is just stuck under the PCL. So it in MRI it looks like another PCL. Both the PCL and meniscus flap appears black. So both appears black. One above one is PCL, then below one is meniscal flap. So that's why it is double PCL. That's a double PCL sign
Okay, sir.
for bucket handle tear.
That's a nice explanation, sir. Sir, probably a non-medical person, Doctor Mr. Shakil asked about his ACL graft become tiered. How he will manage this case if ACL graft tear occur?
That means if a graft is torn and he has the unstable knee, in that case he needs a revision
Okay.
ACL reconstruction. In that case, he need to see a doctor to examine him so that if he needed any revision surgery with in case of revision there are some associated procedure, so you need to see a specialist for that. He might
Thank
need
you.
ACL revision.
Thank you, Mr. Shakil. I think you got your answer. Dr. Asifuddin Ahmed Badhan, he says a question. Uh, uh, Sir, you say that WW zone, there is a less chance of healing. If there is a tear in this zone, will we go for surgery or we will manage it conservatively?
Actually, wide zone, the healing potential is very low. So, in case of, it's better to do the partial meniscectomy. But in Western country, they go for repair for every kind of tear nowadays. The only idea is to save the meniscus. Even they discuss with the patient if patient may need another procedure after repair if it fails. So, I think in our country, it's better to do partial meniscectomy
Partial.
in
Thank you,
wide
sir.
joint.
Okay, sir. Sir, Dr. Hasib asked a question: why recurrent swelling occurs in meniscal injury? Why recurrent swelling in the knee occur in meniscal injury?
Recurrent swelling, meniscal injury effusion occurs. One of the causes the flap due to tear. It causes reactive effusion. That means it's
Yeah.
friction within the joint in between movements. So it causes effusion. Another cause is in case of degenerative tear. Also from tear, there are some chemical mediators also released that can cause effusion also. Main cause is friction between the condyles and plateau.
Okay, sir. Sir, if is there any role of PRP in meniscal injuries? Sir? Role of PRP. There are some
Actually,
sir.
I went to several literature. Actually, there is not so many good evidence for PRP, but PRP is used in case of early type grade 1, grade 2 meniscal tear, but no good evidence for use of PRP for meniscal tear in literature.
Okay, sir. Sir, Dr. Abdul Aziz said a question: can we do meniscal transfer in osteoarthritis knee? Uh, he has an innovative question, I think. Can we?
Actually, in case of osteoarthritic knee, You can do by meniscal transplant. You can't meniscal transplant can't help in advanced osteoarthritis knee, because you need total knee, because the source of the pain is not only meniscus, it also the cartilage damage. So it can filling the space, but not improve the cartilage regeneration. So I don't think the meniscal transplantation is good for osteoarthritic knee.
Sir, sometime we found in tibial plateau fracture there is a associated injury of meniscus. What you do, sir? You fix it at the time of fixing the fracture, or you do it later?
In case of plateau fracture, the main idea is to first you have to address the bone fracture first. After healing union of the bone, then you go for treatment for the meniscus. So you have to do fracture first, fix fracture first, then go for meniscal treat for meniscus.
Okay, sir. Sir, many of our viewers asked a question: what will be the ideal postoperative protocol of meniscus surgery?
Okay, post-operative protocol. In case of partial meniscectomy, it's like ACL reconstruction. You don't need to tell the patient to not weight bear. The patient can weight bear as tolerated from the day 1 or day 3. Started quadriceps exercise and range of motion exercise as tolerated. But in case of meniscal repair, you have to tell the patient to not to wear bear at least for 4 to 6 weeks, and not to bend the knee. That's the main difference. Otherwise, the other things are almost same.
Okay, sir. Sir, thank you for your nice elaborated presentation. And there are some requests to you to take a lecture on ligament injury of the knee. A lot of our viewer are, said they are benefited from your lecture. So, sir, thank you for your nice elaborated lecture, and hope we will see you again, and we will organize an more webinar on ligament injury if possible further
Yeah,
date.
if possible, we'll meet again. Thank you very much for allowing me to present the orthopedic made easy. This is a nice initiative. I think every junior doctor will help. They will get many information from these lectures, and this will help in their study and in their practice. Thank you very much for all the viewer for patience hearing. Hope see you soon. Allah
Thank you,
Hafiz.
sir.
Goodbye.
Thank you, sir.
Thank you very much.